it would be really helpful for you if you can give us some feedback on the presenter, on our presentation in general, and comments and questions that you might have for future webinars. We will have the lines muted during the presentation, but we will unmute at the end of the presentation, and we very much encourage you to ask questions and comments both aloud and through the chat box. Please feel free to enter questions into the chat box all the way through the presentation, and we'll keep an eye on it so that we're primed to ask questions once the presentation is done. And now I'm going to turn it over to my colleague, Dr. Lisa Letourneau, to introduce our speaker for today. Lisa?
Great. Thanks, Kelly. You hearing me okay?
I am.
Hi, great. Super. Thank you. Well, thanks for inviting us all in here, and thanks, everybody, for joining. I'm pleased to introduce Beth Bortz as our speaker today. So Beth serves as the president and CEO of the Virginia Center for Health Innovation since March of 2012. Prior to that role, she served for 9 years as the executive director of the Medical Society of Virginia Foundation, where she developed and led programs in healthcare quality improvement, medication assistance, public health awareness, and physician leadership. She's also served several other roles, including serving as the senior program officer and deputy director for the Virginia Healthcare Foundation for 7 years and a senior associate legislative analyst for the Virginia General Assembly. She also earned her undergraduate degree in economics and government and her master's in public policy from the College of William & Mary. And we're just thrilled to have her here with us today to talk about the work she's doing through the Virginia Center for Health Innovation related to choosing wisely and high-value care. So, Beth, pass it to you.
Great. Thank you so much, Dr. Letourneau. Can everyone hear me okay?
Yes.
Great. All right. Well, it is my delight to be here today and to share a little bit with you about the Virginia story. And I would encourage everyone, as you have questions, to put them in the chat or to ask them live at the very end. I look forward to answering them. I thought it would be helpful for us today for me to start just by giving you a little bit of background about who the Virginia Center for Health Innovation is and how did we get involved in choosing wisely work. So we were founded about 8 years ago now. We are a nonprofit organization, very much a public-private partnership in that we do get some funding from the Commonwealth of Virginia. The majority of our funding, however, does come from private sources. Our mission is to accelerate the adoption of value-driven models of wellness and healthcare. And we really are seen as a trusted convener of all those who have an interest in healthcare. And so you will see in a second that we very much have a multi-stakeholder board of directors as well as an advisory leadership council. And our role is really to bring those partnerships together to see if we can work on important projects where we go after potential grant funding to lead that work. And so in the 8 years, we've now secured a little over $23 million in grants on behalf of Virginia. So this next slide, I know there's a lot of names on there, but I just wanted you to get a sense of when I say we have a lot of folks sitting at the table, we have a lot of folks sitting at the table. So you'll see, from AARP Virginia, down to WorkPath, which is a startup technology company, to health systems, health plans, pharmaceuticals, labs, large businesses, state government, medical specialties, all, at the table. So what do? We have 4 core services that are related to our mission, but the one, and you can all read them there, but the one I really want to talk about today is that number 3, which is leveraging data and analytical resources to inform and enable healthcare providers, public health professionals, government, community organizations, employers, and consumers to make better decisions. So we really work to be that, trusted source that finds the data and puts the information out there to our partners. And so when we started our work one of the things very quickly that got attention was the National Choosing Wisely campaign. We found that across our different stakeholder community, Choosing Wisely resonated well. The business community in particular was very interested in, how could there be things that, providers are routinely doing that they know to be unnecessary, potentially harmful, and what can we do in the Commonwealth of Virginia to do something about that? And so what we developed a plan of attack. First, we really wanted to make sure that all of our partners were on board with the Choosing Wisely campaign and the need for us to not only improve education, but actually to measure the provision of low-value care in the Commonwealth. And in order to do that, we are fortunate in Virginia that we have an all-payer claims database that came online right about the same time as the start of our center. We also were fortunate that Virginia's all-payer claims database has as its kind of backbone a partnership with Milliman. And Milliman, at the time that our APCD was coming on board, had developed something called the MedInsight Health Waste Calculator, which ties very closely, and I'm sure many are familiar, to the Choosing Wisely campaign, and really looks at how do you take those tests and procedures identified by Choosing Wisely and do all the very complicated coding to determine how much of this is happening in a clinically nuanced way. Once we had that information, the idea was that we would share that data with our partners and make sure that they accepted it, that they found it to be valid, to start building consensus and to develop an action plan, and then finally to identify and test some improvement strategies. So I mentioned that, we started with building consensus around Choosing Wisely. And not just the idea of choosing wisely, but also the importance of measuring what we thought was happening around unnecessary care. And so you'll see there, I just wanted to give you a sample of, what I called, in 2015, 2016, my roadshow. I went out and talked to, our health plans, our medical providers, our businesses through the chamber, the General Assembly and its Joint Commission, anyone engaged in population health, our federally qualified health centers. It was really important that we bring kind of a variety of our stakeholders into the conversation. And so then, the next, as I mentioned, a wonderful thing we had in Virginia was an all-payer claims database. And I want to give you a sense of the richness, I believe we in Virginia have participating in sending medical and pharmacy claims to Virginia Health Information, which is our partner that runs the APCD. We have 10 of the largest health insurers in Virginia that are submitting about 55% of the commercial data. We also have all of the Medicaid and Medicare fee-for-service data. So all in all, we have a little over 5 million of the 8 million Virginians, their claims are in our APCD. So when we ran that APCD data through the Milliman Health Waste Calculator tool, the tool is built such that right now it is looking at 48 measures. Now, as you all, I'm sure, know, Choosing Wisely has identified many more tests and procedures than 48. But we, in partnering with Milliman is only looking at those tests and procedures that can be fairly evaluated using only claims data. So, as I'm sure you're aware, many of the tests and procedures would require additional clinical information that we can't evaluate at this time just using claims. But so we focused on those that could be fairly assessed with claims data. We have done this now for about 5 years. What you're seeing in front of you is the data that we actually just released in January. There's always a lag in our data so this data that you're seeing is through December of 2018, so it's about a year old. I will tell you that we actually get the Medicaid and the commercial data faster. We're able to get that data in about 6 months. It's the Medicare data waiting on the feds that takes the longest. But in looking at that data, you'll see there, with just looking at 48 measures, over $539 million in unnecessary services spent, and that represents more than 1.72 million unnecessary services. So when we started putting out these reports, you can imagine that attracted a good deal of attention. So if you do a little bit deeper dive, we found, for this most recent year of data, that 36% of the members were exposed to at least one of those 48 low-value services. 31% of those services measured were considered to be of low value, and that represented a little more than $8 per patient per month in unnecessary claims. So we also look at, of those 48, which ones represented the biggest percentage of dollars for us. There are multiple lenses by which we can look at our data. We have looked at it by, the potential cost. We have looked at it by, you'll see there's a column looking at harm. We have looked at it by the potential harm. We have also looked at our data by, you'll see the last column there says low value index. And that number there lets us know what percentage of the time is the service being provided in a way that it is considered to be of low value. And so, for example, that first one, the baseline labs for patients, low-risk patients undergoing low-risk surgery. So this is basically your drop the pre-op, if you will. 82% of the time, that is considered low value. Whereas, the EKGs, if you look down a little further, most of the time clinicians are getting it right. Only 15% of the time is it considered to be of low value. The difference, of course, is that the EKGs have a bigger price tag. So it still results in up there in our top 4, but there is a difference. And it's been really interesting as we've worked across our different groups, stakeholder groups, that their interest varies. I'll tell you, employers care a lot about the dollar amount. Clinicians typically care about the harm. And system managers, health system managers, are most interested in the low value index because they really want us to choose things that aren't going to be needles and haystacks for them to work on reforms. So as we started to share that data out with our different groups, I just wanted to share with you some of the things that we learned. The first one is that word choice matters. When I talk to employers, they love the term waste. When I talk with physicians, that strikes a nerve, and they would much prefer you refer to it as unnecessary or low value care. And here, as I said, depending on who you talk to, they're going to focus on a different piece of this. Another lesson I would share is that when we talk to clinician groups, there's always someone who asks about medical liability concerns. And we have done our best to reassure folks, but that is always a question. And then, there's also always someone who asks, rightfully so, about the consumer education piece to this. Are we going to be focusing on the consumer population as well as the provider education piece? So how do we, what did we do to build consensus and develop our action plan? We then began to work. There was an emerging national task force on low-value care that was being led by the folks at the University of Michigan, Dr. Mark Fendrick, and the VBID Center, and then Dr. Mike Chernew out of Harvard. And so we eagerly joined that group, wanting to learn from others and to share our data. And it was exciting because, truthfully, in the early days, Virginia and Washington State were really the only 2 states that had the ability to kind of do a deep dive at a state level. Excuse me. The next thing that we did was we wanted to establish a health value dashboard. I'm going to talk about that more in a minute. And then our next step was to begin pilot projects with our interested partners. So the dashboard. As we started to run this data looking at low-value care, I will tell you that one of the early pushbacks that I got was that, it was important to look at the complete picture of value in care, both in terms of, are we doing too much low value or are we not doing enough high value? And then the third question actually became, do we have the infrastructure in place in the Commonwealth of Virginia to appropriately measure and reward value? And so we determined that we needed to develop a dashboard with a series of indicators and measures so that we could see how good a job we were doing at improving value in Virginia. So as I mentioned, 3 aims: reducing low-value care. You will see here we looked at things like, avoidable emergency room visits, low-value services as captured by the waste calculator. You'll see the 5 that are listed there were our initial 5, which were the 5 that were adopted by the National Task Force on Low-Value Care. In a minute, I am going to show you that we've actually subbed a few in Virginia to align with our new Smarter Care Virginia initiative, but many of those are the same. And then looking at inappropriate preventable hospital stays. Those were our low-value care measures. We also looked at increasing high-value care. So we looked at children and adolescent vaccinations, diabetes care, and cancer screening rates. And then finally, I mentioned making sure we have the infrastructure. We started to look at claims in the APCD. Obviously, if we're going to be reliant on the APCD to provide us a good amount of the data, it's really important that we have as rich a database as possible. And then we also wanted to look at the payment in Virginia to see if payments were becoming more value-oriented and if they were placing providers at risk for their performance. So you'll see here a visual of our dashboard. If this is something that's of interest to you, you can go to our website and you can always pull up both this year's and past year's versions of the dashboard. You can look at it not just statewide, but you can look at the regions. And this top sheet you're seeing, we found that folks like red, yellow, and green. That was an easy way for them to identify how things were going. But if you actually wanted to dig into the real numbers, we have all that background there as well. And so once we had all of our stakeholder groups agree on that dashboard, the next step was really to see what we could do to start to take action to improve our performance. And so we focused initially on that aim 1, reducing low-value care, and came up with our Smarter Care Virginia initiative. So, I know based on who this group is, I don't need to go through these definitions for you. You know what choosing wisely is, and then I've talked about the rest of these. So I'm going to jump forward. As we were starting to run our data in partnership with the APCD and Milliman, we wrote up some of what we did, and we were excited to see that it was accepted by Health Affairs and actually wound up being the 3rd most read article in Health Affairs in 2017. That was fortuitous because it started to get us some national attention, which then led us to a $2.2 million grant from Arnold Ventures, which is a philanthropic organization. They gave us the funding to launch a statewide pilot to reduce the provision of low-value services. This is an initiative that's going to span 3 years, and then there's an additional 6 months for the evaluation. That's, of course, necessary because, remember, our main data source is claims data, which has a time lag. And we developed a 2-part strategy. And so when you think about smarter care, first, it's important to know that we focused on just 7 of those 48 health waste calculator, choosing wisely type measures. And we purposely chose ones that we deemed to be provider-driven. And by that, I mean we chose things that we thought no consumer would ever come in and ask for. Consumers don't typically ask for a PICC line without a nephrology consult. So we really wanted because we know it's going to be an even harder strategy when we have to have both provider and consumer strategies. And so in our first phase, we focused just on those provider, but we have promised that we will begin to prioritize the set of consumer-driven measures for phase 2. And for that, think about things like low back pain, antibiotics, pap smears, things that you might have a patient come in and ask for. The second piece of this two-part strategy is the creation of an employer task force. And I'm going to talk about that a little bit more, but that was really important as well because we realized very quickly that if we were successful, if we were able to achieve a reduction in these low-value care tests and procedures, that actually our good faith partners were in the current financial system going to lose money. And so we knew we needed to be moving toward payment reform, and in order to do that, we needed our employer community engaged. And so we put together, you'll see here the project leadership team, in addition to our own organization and all the board and advisory leadership council members that we have. We're very fortunate that Virginia's governor and our secretary of HHR are both physicians, and we're both very interested and engaged in this work. We had the full support of our Hospital and Healthcare Association and our health systems who actually helped us write the grant proposal. I mentioned Virginia Health Information that runs the All-Payer Claims Database in Milliman. We also early on got the endorsement of the Virginia Business Council, which represents those Virginia employers that have revenues of $1 billion or more. So this is the very large Virginia employers. And then we put together, what we can consider to be kind of an all-star evaluation and faculty team. And you'll see there, given that this is a ABIM call, Daniel Wolfson is involved as project faculty along with, the rest of the all-star cast. And so the core components of our project, we have a clinical learning community that is working to reduce 7 measures. We have the employer task force, and the goal is that at the end, they all come together and we work to create a long-term plan to improve health value. So in terms of project aims, we have promised Arnold Ventures that we will achieve a 25% relative reduction in the 7 measures that we selected. And then you'll see, additionally, we want to make sure that we improve clinician competence in reviewing their data reports. I'm going to talk about that more. We still don't know which interventions are most effective in reducing some of these provider-driven measures, and so we're hoping to learn a lot about that. We're allowing each of our participating health systems to have a different strategy, and we're evaluating those. We really hope that we will reduce the harm that is done to patients from these unnecessary tests, and then also working to educate Virginia employers on the actions that they can take. So our clinical learning community, this really is perhaps the most remarkable piece of what we're doing. We put out a really short 24-hour, who wants to do this with us? We have to, submit a grant. And we heard back from 6 of Virginia's leading health systems, 3 clinically integrated networks that work with those systems. You'll see there Ballad, Carillion, Inova, HCA, Centera, BCU, and then their clinically integrated networks. They represent over 1,000 practice sites, nearly 7,000 clinicians, and it actually serves all 5 Virginia health planning regions. So this is a pretty large initiative working to reduce those 7 tests and procedures. We randomized those 6 systems into 3 cohorts. So cohort 1, which includes Inova and Centera, they launched in August of this past year. Cohort 2, which is Ballad and Carillion, think more the west and southwest parts of our state, and they launched in November. And then cohort 3, which is the central region, mostly here, Virginia, BCU and HCA, they'll be launching the first week of March, so right around the corner. Each of those health systems is establishing a clinical leadership team that is guiding their work, and the active intervention period for each cohort is 18 months. So what do we give them when they say, yes, we're in? The biggest deliverable that we provide them is that from our APCD, we will provide each of their providers by MPI number with a report on how many of the 7 low-value care tests and procedures they provided. Now remember, there is a data lag. This isn't current, but those reports, the systems are getting those reports. They can be sorted by provider, by practice. You can, look at where the variation is greatest. And so that is really valuable information for those systems that they had not had before. Then our faculty provide CME-approved webinars that help them with the challenge of changing behavior. We also have faculty office hours. We convene the system leads, those clinical information team or clinical leadership teams, meet with our project leadership team once a month and do a call where we troubleshoot. And then we have an online platform for the entire project called the Virginia Health Innovation Network, where they can draw down tools and resources. We're very fortunate. ABIM has provided us with, some great resources related to choosing wisely. And so we give those systems all of those things. So, when we look at what measures did we choose, we started with drop the pre-op type measures, although I'll give you a hint that actually on our last cohort call, some of the clinicians don't like the term drop the pre-op, so we might actually be changing that a little bit. But really looking at, labs and imaging for low-risk patients before low-risk surgery. And there's 3 of those measures. And then there are 4 treatment and screening measures. 2 relate to cardiovascular, stress cardiac imaging and EKGs. Then there are imaging tests for patients without symptoms or signs of significant eye disease. And then, as I mentioned earlier, there's one related to PICC lines in stage 3 to 5 CKD patients without a nephrology consult. So, so think that's phase 1. That's really our health system learning collaborative, all working to achieve a reduction in those 7 measures. At the same time, our employer task force meeting to really try to understand the issue of low-value care, to understand choosing wisely, to understand what they might be able to do to mobilize for change. And so you will see here, here is a slide just showing you the members of our task force. I'm especially proud to point out we have both the largest private and public employers in the Commonwealth on this. We also have folks that are both fully insured and self-insured on the task force. We cover all regions of the Commonwealth, and we have a variety of health plans represented that these employers utilize. So we really tried to get a good mix. Now, I will say the one question that we do get is, do we have small employers represented? And the truth is that's really, really challenging because most small employers don't have a person who could even serve and dedicate time to this. What we tried to do to get around that is that we do have, for example, the NFIB, the National Federation of Independent Businesses, Nicole Riley there serving on behalf of her members. Similarly, we have, a chamber serving on behalf of their members, the Virginia Association of Counties serving on behalf of their members. So there are a few that represent some of those smaller size employers. So the task force, it will be meeting 6 times over 22 months. We've asked them to actually help us with the prioritization of the consumer-driven measures for the next phase. And they're going to be working with our clinical leadership teams from the health system to develop a long-term plan to improve health value in the Commonwealth. And so that is our ultimate deliverable once we've kind of gone through this process and we think we understand better how we can drive change. And the idea is that we will present that plan to both the governor and the Virginia General Assembly's Joint Commission on Healthcare in 2021. So, let me kind of conclude my remarks with some early lessons, and we are very much still early days. We feel pretty good that we've actually figured out how to run each quarter. I tell people 49,000 pages of reports because we have 7 measures and 7,000 clinicians that we're giving them reports on. So, that's huge. One of the things that we have found is that even in this day and age, most of our participating providers are not used to seeing their own data, especially related to low-value care. So, that is a big piece. And then I want to emphasize that our approach has always been that clinicians want to do the right thing. We do not do this in any way as a shaming exercise, because oftentimes we learn things from our partners that suggest that most of the time these are system failings, not individual failings. And so I'm going to give you 2 examples that really highlighted that for me over the last 6-month period. So the first is that as we were kind of getting this rolling, one of our physician partners who also happens to serve on the U.S. Preventative Services Task Force said, "Can you run my reports?" And I said, "Sure." And, as long as you share with me your MPI number, we can run a report and you can look at it. And I'd be really curious before we roll this out on a big scale, for you to let me know how you think those reports look. And so we ran the report, and this physician called me and said, "Beth, this can't be right." And I said, "What do you mean it can't be right?" And he said, "I'm one of the people that worked on the recommendation about vitamin D screening being a low-value service. I can't be providing this much vitamin D screening." And so I said, "Well, is it possible maybe that there's a PA or an NP who works with you that is being coded under you? Maybe that's why it's showing up." And so, we we did a little troubleshooting, and then we both agreed, we would look into it further and get back to each other. And this physician called me about 3 days later and said, "It's me. I'm ordering all that vitamin D screening." And I said, "What do you mean?" And he said, "It's part of a bundled lab. And it's a bundled lab that I've been ordering as part of folks' annual physicals, and I didn't even realize that that was a piece of the bundled lab." And so I tell folks that because in that case, we could have done all the CME in the world about vitamin D screening, and this clinician would not have realized that he was contributing to the problem because it was part of a bundled lab. And so, it's really important, I think, to show folks their data, let them sit with it, and let them come up with why the data might look the way it does. The second example I want to give you is similar in that I was doing a presentation, and it was to a group of primary care physicians, and they said to me, "Well, this is really unfair." And I said, "Well, what's unfair about it?" And they said, "Well, we're the ones that, that some of these tests are going to be attributed to because we are the ones ordering it, but it's because our either surgery team or anesthesiology team at the hospital requires it. And my patients have to have these done in order to have their surgeries. And so, we know that they're unnecessary, but we don't have a choice." And in fact, one of them said to me, "I stapled the Choosing Wisely recommendation to this order every time I order it, but it doesn't help. The surgical team still requires it." And the interesting thing was within that particular health system, when we had that conversation and included the surgical team said, Well, we changed that 18 months ago. We don't require it anymore. That's no longer part of the standing orders. And so right then we discovered, you know, sometime it will be the standing orders that have to be changed, and that's going to be important, and that's why these have to be system-wide conversations with the right people in the room. But also, sometimes even when you've made the change, it's not communicated out to those that are actually doing ordering. And so, you know, I want to conclude with my takeaway has been really when I go out and talk to folks about engaging is to not preach. You know, you have to let the clinicians look at the data and let them start to tell you why they think the way it looks the way it does and what they want to do about it. And I think that will be effective. So with that, let me close and see what questions you all have for me.
Great. Well, that's terrific, Beth. Thanks so much. This is Lisa, and thanks for your energy and enthusiasm and your experience sharing it with all of us. So that's really impressive. We certainly encourage folks to unmute if you'd like to jump in and ask a question, or to use the chat function online to ask a question. So let me just pause for a minute and see. I certainly have some questions I would ask, but let's see if others. Not sure if that was someone trying to talk.
And everyone has been unmuted. If you would like to ask your question aloud.
Sure. I have a quick question here. What did you use for your monetary basis for the value of the low-value care measured?
Sure. So in the Milliman MedInsight HealthWiz calculator, they actually, while they actually have the actual cost data, they're required by Virginia law to use a proxy measure that is within, you know, I think it's 1.5%, but they've had to structure it that way so that no one could go into Virginia's APCD and kind of go work backwards in order to figure out a specific contract, but it is the actual paid claims for Virginia.
So that's a claim value, that's not a cost to perform the given service or test?
That's correct.
Okay. Did you discern inpatient versus outpatient in that calculation?
So we can do that, and in fact, with the health systems that we are working with, they are breaking it down to look at that. We haven't publicized it that way. We really, you know, when we share the data, when I go out and share the data, I try to keep it very high level because, as I shared, I'm never about shaming. But yes, the systems themselves can break it into inpatient and outpatient.
Okay, last question. Have you seen much pushback as it relates to the measured services being in the ambulatory space and therefore revenue opportunities?
We really haven't. You know, I will say that when we started this and when, you know, when we applied to Arnold Ventures for the funding, the first pushback that I got related at all was actually from Arnold saying, why is it that the health systems would do this in partnership with you if they're going to lose money? You know, what's in it for them? And so I actually surveyed the 6 and asked them to help me answer that question. And the interesting thing was all 6 pretty much said some variation of, while this is a goal to achieve a 25% relative reduction, this is still a relatively small number for us. And we really want to learn from this as our ACO side of the house is getting into increasingly more risk-based contracts. we think this would be a really valuable opportunity for us to learn so that we do a better job in negotiating those contracts moving forward. So they recognize that they will be losing money, but they felt that it was in terms of the learning that they would achieve.
So we have a question in the chat box, which is, can you explain the CME webinars? Who drafts the content, hosts the sessions, and do you track who watches them?
Sure. So the content is actually provided by our faculty. So we actually had one today that was done by Drs. John Massey and Catherine Sarsian out of UCLA, who did one related to specifics of implementing change. Dan Wolfson does one for us as well, and I think Kelly and Zach might even participate in that one. And so these are recorded, and so the way we have designed them is such that they're for each of our, we do them live for each of our cohorts for their clinical leadership team. So those teams participate live and can ask questions. We record them, and then any of the 7,000 clinicians participating in the project can listen to them, and then everyone can earn CME by watching it. So we do record who has attended them. Any other questions?
Great.
We have another one from the chat. Was it difficult to get some providers on board? Are there incentives for them to lower their unnecessary care provided?
So I thought it would be difficult, and the answer is no. It was shockingly easy to get the providers on board. I will say that we have had great enthusiasm for the project in Virginia. In fact, after we received the grant, we actually had to turn 2 additional health systems away who approached us after we got the grant wanting to participate, but we just didn't have the capacity to go beyond kind of 1,000 sites and 7,000 clinicians in the first go-round. And I think because we have chosen an approach of assuming that clinicians want to do the right thing, we've gotten great support. I do think folks want to do the right thing, and I think that everywhere I've gone, our physician community is eager to see their data and really to try to understand it. And there's no negative, like we've made sure that there's no negative right now to them participating. So while there's not any financial incentives for them to participate, there's also no negative repercussions to participating.
Great, thank you. Others, questions?
This is Kelly.
One,
oops, go ahead, Lisa.
Go.
I was going to ask a question, but you go ahead.
Okay. Yeah, so in some regions, including my own, there's a real strength, shall we say, of the hospital-based health systems that can have conflicted incentives in terms of, restraining utilization even of low-value care, because it's also a revenue center. And I'm wondering, how has that played out in your community? Have the organized systems been active partners?
Absolutely.
Like?
And in fact, when we first started this work, the very first meeting that I had with the 6 systems who said they were interested in participating was with both the chief medical officers and the chief financial officers for the 6 systems, because my biggest fear was that, the clinician side of the house would be on board, and then the financial side of the house would realize that this was going to cost them money and shut it And so we had really honest conversations in the beginning. And, as I shared, I think they all decided that the opportunity to learn from this data and to learn about how they drive change based on those performance reports was worth the loss in revenue.
Great.
We have another one from the chat. Did you implement any point of care reminders or best practice alerts in EMRs to help with the initiative's success? And if so, what EMRs are your providers using?
Yes, so that's a great question, and we're still kind of early days in the implementation phase because, as I mentioned, two of the 6 systems aren't even on board yet. They'll come on board in March. 2 of the systems actually just got their first data reports about 2 weeks ago. So really, only 2 of the systems, the ones that kind of came initially with a kickoff of August, are at the point where they're starting to make system changes. Both of those are looking at some point of care decisions. Both of those are Epic systems. But we are allowing each of the systems to kind of design their intervention. So it's not required that anyone do that, but I expect that many of them will be exploring that.
Great. And this is Lisa. I'll ask another question. Are you aware of other communities around the country? I know I've seen, was it Washington State use the Milliman Waste Calculator, but other regions or states that are taking this on as kind of a...
Sure. The really neat thing is I will say that usually at least once a month another state reaches out to me about wanting to do this. Washington State and Virginia have, we both started about the same time several years ago in doing this. And I will say, and we work very closely with Washington. It's been great to see that actually when we ran reports, our results were very similar. That reassured us actually that, the data was telling, telling the same story. But I will say we've had a little bit different strategy. Washington State is run by the Washington Health Alliance, and they're really employer-driven. Whereas our work here really the initial focus was those health systems coming together to drive some of this. And so I think what you will see in Washington, for example, they have taken a much more public approach in that they actually publish by practice performance on these low-value tests and procedures, whereas we have taken the data directly to the clinicians and expected them to do the right thing. So it's just a different strategy. It'll be interesting to see, which strategy is more successful. But I will say, I have now either done or am scheduled to do presentations in Rhode Island, Maine, Delaware, Utah, Tennessee. So there's a good deal of interest by other states. Oh, in Florida.
Wow. Super. Other questions, comments?
This is Kelly. Just one question I have. Other than the working with the employer groups, is there any other patient-driven education that's going on?
There is not. And that's a great question. And I think as we get to, we felt that for this first phase where we were, as I've shared, really focusing on measures that we felt were really provider-driven, that we didn't need to introduce that piece yet. But certainly for phase 2 of what we're planning, which will be, tests and procedures that patients do routinely ask for, we are definitely going to have a consumer-facing component to our work. So that will be new for us.
Great, thank you. And there's another chat question. Do you have experience with any clinical decision support companies positively helping these efforts, jump-starting utilization stewardship versus individual Epic builds for interventions?
Yes, and now that you asked that question, one of them that works with ANOVA has just left my mind, and hopefully it'll come back to me. But there are, and there's more, I will say there's more every day in this space, and so at BCHI. We don't endorse or, work with any of them directly, but if our health system partners want to, we encourage that. And in fact, I will say that Milliman has been a great partner in that they, as you can imagine, the health waste calculator is their proprietary intellectual property, but they have allowed, as long as our 6 participating systems have signed a confidentiality waiver, they have actually allowed them to kind of see behind the screen, if you will, and all the coding involved, so that their clinicians can really understand what's involved. And in fact, they're also helping them if they want to run kind of a companion report during the time of this active intervention from their EHR. Milliman is working with them to do so. And both of our first 2 systems, I will say, are working to do that. They are interested in, comparing their EHR data to what's being reported from the APCD. And that's an interesting finding, because when we started this, when I was putting together the grant proposal for Arnold Ventures, I actually asked the 6 systems, there were 2 ways that we could do the data piece of this. We could either run the reports centrally from Virginia Adult Payer Claims database, recognizing that there would be a time lag in the claims data, but also recognizing that we would be able to pay a staff at the APCD to send out those reports, and there would be consistency across the 6 systems. Or we could purchase the health waste calculator tool for each of the 6 systems to use on their EHR. And I actually asked the systems which was their preference, and they universally said that they wanted us to run the reports from the APCD because they were concerned that given the time period that we had and given the tremendous demands that their information systems folks were facing with other priorities, that it wouldn't get done. And so we did go the route of using the APCD, but what's been interesting is once they started seeing those initial deep dive reports, and I should share that our friends at Virginia Health Information have been awesome, because they have customized those reports to however the individual systems are sharing data with clinicians. So there are some detailed Tableau reports, but they really have worked to make them fit within other information that clinicians are already used to seeing. But when they started sharing those reports, they got so into it, they decided they wanted to also look at their EHR data. And so now we're kind of going back and adding kind of both functionality, if you will. So, I think that speaks a little bit to once they see the data, they become energized by the data.
Great. Others? Super. All right. Well, it's really been a fascinating project and conversation. Thank you so much, Beth, for being willing to share, and again for your leadership on this. Really, really interesting, and it's actually planting some seeds for me here in Maine as well, where we are also using the Milliman waste calculator. So I think I will be in touch about that. But unless there are any other questions or comments, Kelly, I will turn it back to you to close up.
Super. Thank you, Lisa. And also, thank you, Beth. Great presentation. I think you can tell the level of interest by all the great questions that were asked. And we'll hope to hear more later on when you have even more results. So thank you for joining us today, and thank you everybody who attended. Just a reminder that, again, please fill out our brief evaluation at the end of the webinar. We'll be sharing the recording on Workplace, or you are welcome to email either Kate or myself to get a link to the recording. And thank you, and have a great afternoon.
Thanks, everyone.
Thank you. Thanks again, Beth. Bye-bye.